Good evening. Good evening.
Hello, good evening, Osama. How are you?
How are you? Very good, very good. How's things?
Yes, it's okay.
Yes, I had a problem when I share the screen. Sometimes the screen down is obstructing some of the slide. I'm not sure how to solve it. Do you any clue?
Hi, Osama.
Hi. When I share the screen, sometimes I couldn't see the what you call participant and the questionnaire. It came to the bottom of my screen. Sometimes it's hiding the picture for me.
Okay, so just close it, or the picture you can minimize it. Just minimize the picture up. There is a, if you'll go to up, no, if you'll go to up, there is a slash, 1 slash, 2 slash, 3 slash. Just click on the 1 slash. The whole, it will be one picture, only your picture.
So, but there's no, when I share it, what I mean, it's become the screen, it's hiding, my slide is obstructing me something. I'll check it again, just 1 second, if you had 1 minute, I'll just try it now.
Just let me show you.
I was
Now
just
you are sharing?
just if you don't mind.
You are sharing, right? You are sharing?
Yeah, just to try. Yeah, I just tried. Yeah, I'll just try it very quickly.
Okay. Now you are sharing. Now the whole pictures of us on your right side.
No, that doesn't want to increase. That's what I mean. The bottom one, I'm not sure how to hide it down.
Up, go up.
I'm not sure what's wrong there. Anyway, I think it's, I'll do it after, anyway, don't worry.
Anyway.
So my good morning. Good morning from Miami. So my presentation is already videotaped. So I'm not giving it live, but I'm available to. Are we going to have a question and answer period or not?
Well, yes, I think that we will have. I think that this session is by Dr. Khalid Ayash. Dr. Khalid is here. Dr. Khalid. Anyway, now the time, because it's over, so we can start. Dr. Osama, if you don't mind, we will start, and we will start with the diagnosis of infectious keratitis, Sandeep. So I think that Dr. Sandeep will. So Dr. Edward, yes, we will have questions according to the time. Depend on our time. So if we will have a time, 100% we will do questions. I don't know whether Khalid is with us.
Okay.
Dr. Khalid Ayash. Dr. Khalid. No. Okay. So Dr. Sandeep, you can start, please. And Dr. Sandeep will start with us the diagnosis of infective keratitis. I hope that other speakers, they will be mute, if you don't mind. So
Yeah,
other speakers.
Can you see my screen now?
Dr. Khalid is with us now.
Yes, hello,
Hi,
how are
Dr.
you?
Khalid. We are starting with Dr. Sandeep.
Okay.
And we are starting with his start lecture, that's diagnosis of infective keratitis.
So as the program, yes, okay.
Yeah. I think that
Okay,
there is a sound coming from, I don't know where. That's the adhan. So I think that we need to mute all. Yes, Dr. Sandeep.
Yeah, good evening, everyone. I hope you can see my slides now. Are they live? Can you see them?
Yes, yes, please proceed, Dr.
Okay, so diagnosis of infective keratitis is not something which is unusual. We get to see them every day in and out. Coming to first type of keratitis, which is very common, is a bacterial keratitis. Of course, the first thing is the sign and symptoms, which brings us the diagnosis. Usually the patient presents with painful eye, lid edema, light sensitivity, tearing. There is a history of contact lens wear or some sort of an injury. Sometimes the patient is on steroids. The main thing is they have an ulcer which is sitting and excavating the epithelium, Bowman's layer, there is a stromal necrosis. The striking feature is they have endothelial plaques and hypopyon, which is not very thick, and a mobile hypopyon. But when you come to diagnosis, the most important point is collecting the sample from the cornea, which is called the corneal scraping. Now, it can be done with either a blunt beaver blade, or the better is the Kimura spatula. The idea of doing the scraping is you should tie and take the scraping from the edge of the ulcer, and also from the bed without perforating the ulcer, and then you send it for in 3 different slides for gram stain, Gimsa stain, PAS stain, and KOH mount, and sometimes you also do special staining techniques. We know that corneal scraping is the heart of diagnosis of any keratitis. There are various ways of doing corneal scraping, but most commonly what we do is we put the patient on a slit lamp with topical anesthesia and then use a beaver blade to scrape the cornea. The ideal corneal scraping should be that you got to see some epithelial cells when you plate these the scraping and stain them with any form of staining. If you don't see epithelial cells, that means your scraping is not adequate. You should go back and repeat it. Coming to the next diagnostic thing is the plating of the scraping, which you have taken into various media, like for example, the blood agar, chocolate agar, thioglycolate broth, brain heart infusion broth, and sour dextrose agar. If you're suspecting canthamoeba, you have the SDA media with E. coli on it. Sometimes you don't get enough material on corneal scraping, and then you can do what is called corneal biopsy. And this is used a 3 mm punch, which is a skin punch available. You have to be careful from where you're taking the biopsy, try and avoid the visual areas. The commonest, one of the commonest organisms is staph, which is Staph aureus or Staph epidermidis. Usually they present in the periphery of the cornea like this. They are next to the toxins released by the organism. For example, the patient has got blepharitis, and then you have a growth which is in the periphery. And when you plate these, see them in the smear, you will see this polymorphonuclear cells along with the staph organism. And when you plate them, you will see these colonies on the blood agar or chocolate agar. The next most common bacterial infection is from streptococci. These are again focal suppurative infections. They are more commonly associated with hypopyon. They are very common post-LASIK patients. And here you can see a central suppurative streptococcal pneumonia infection, which is multifocal in origin. And this is also in a patient with LASIK flap. In between the flap, you can see the infection with streptococcal infection. This is an abandoned growth of streptococci, which you can see on a chocolate agar plate. Actinomyces infection, again, it's an anaerobic organism. Most commonly, these are resistant to fourth generation quinones. And these infections are common in patients with any form of trauma, for example, soil trauma or any trauma. So they are sometimes mixed with fungal infections. This is how it looks like. They are filamentous bacteria, which are seen, which is gram-positive and corneal scraping. And the other organism is the nocardia asteroids. These are also very uncommon, but they can also present, especially in patients with corneal transplant. They're usually very resistant to treatment. The other common infection is mycobacteria, which is again present in patients with chronic use of steroids. In terms of mycobacteria, these are become more common these days with the use of quinones, and they don't respond to fourth generation quinones many a times, and we have to give them amikacin. And here you can see a Gilles-Lynchon stain, which is showing an acid-fast bacilli. They grow very slowly, so it's better to diagnose them on staining on peripheral smear. Of course, if you make LJ slope, you can see them growing like a yellow colonies. The most dreaded complication is Pseudomonas. Pseudomonas is usually seen in patients using contact lens or traumatic corneal erosions. They are, again, gram-negative organisms. Here you can see a patient with the post-traumatic keratitis with hypopion, and they're unresponsive to topical antibiotics. And on gram stain, they will show a gram-negative rods on a patient with the corneal ulcer. This is how they look. They have a gray mucoid colony on a blood agar plate. Moraxella is another infection which is also not very common, but is more commonly seen in patients with immunodeficiency conditions and elderly patients, patients on diabetics. These smear shows gram and Gibbs stain appears as broad rods. Here you can see a corneal abscess in a patient with Moraxella lacunata. And here you can see on a gram-negative rods on a corneal scraping. Gonorrhea infections used to be very common, especially in children. These are again gram-negative diplococci, which are commonly seen in Giemsa stain. Here you can see WBC with gram-negative rods, and this is an. Coming to fungal infections, the fungal infections are basically sometimes very difficult to diagnose if you don't have a proper history. Usually the patients have a history of infection with either a soil or a plant infection. Commonest is Fusarium solani. These are most common types of keratitis, especially agricultural. It's very common in India and countries which have agricultural dominant. This is a condition where you can see, first thing, in any fungal infection, normally the infection has a multitude of satellite lesions with feathery margins. The hypopion is very thick, and sometimes they are not mobile. On staining them, especially if you do a pass staining, you'll find they have septate hyphae, and the colonies look very typical of Fusarium. Coming to Aspergillus, Aspergillus have usually, they are again contaminants, usually present in soil. They are grown in the sabro-dextrose agar. And this is a patient with a corneal abscess 3 weeks after trauma. And this is how the corneally looks on a chocolate agar plate. The Aspergillus is typically normally seen as a non-septate hyphae. This is a patient with corneal scraping with a pass stain, and you can see the brown hyphae of this patient. Candida albicans, and Candida is usually seen in patients with immunodeficiency conditions or patients with old age or chronic debilitating conditions. This is what you can see. There's a past stain showing yeast. And the typical feature of Candida on Sabaros destruagar is they are creamy white colonies, and they're abundant on the SDA media. Coming to herpetic infections are much easier on their signs and symptoms. Usually the cornea is anesthetic. The most important thing is the rose Bengal stain. If you do a rose Bengal stain in these patients of herpes, you can stain the dead epithelial cells which are infected, and typical dendritic picture is visible. Of course, herpes presents in a different types of stages. It can have a typical dendrite or a geographical ulcer or a metaherpetic ulcer. So staining them with rose Bengal and fluorescein can give you exactly how the herpes is progressing. We can use a PCR, which is quite significant. It's very sensitive. You can either collect it directly from the corneal infiltrate, or you can do a smearing from the tear film. Both of them have got a very high positivity. The other two more important things these days are the ELISA test and the virus culture. The problem with virus culture, it is time consuming, and it takes a very long period of time to grow the virus. However, as I told you, it's better for herpetic infection to diagnose on clinical picture.
1 minute, Dr. Sandeep, please.
The other common infection is acanthamoeba. Again, acanthamoeba is more easily diagnosed on clinical picture. They have a typical ring infiltrate. The problem with acanthamoeba comes when it mimics or looks like herpetic infection. Usually the patient presents with severe excruciating pain where neural infiltrates. There are usually no hypopion, deep stromal infiltrates. However, if you have a confocal microscopy, you can see these double wall cysts. Sometimes you will see the infiltrates along the nerve. And one of the other ways of diagnosing acanthamoeba is by staining them. You can use a calcium-4 white stain, and you can see a typical double wall cyst. It can be present either in the form of a cyst or in the form of a tropozoid. Okay, thank you very much.
Dr. Khalid, you are mute.
Thank you, Dr. Sandeep, for this very comprehensive and presentation. Our next speaker will be Dr. Razan Al-Bakri. Is Dr. Razan with us?
Yes,
Dr. Razan, yes.
Yes, Dr. Razan, please. The screen is yours. Please start sharing your screen.
Good evening, dear colleagues.
Hello.
I'm very glad to be able to join this great meeting. I'm going to talk about bacterial keratitis in general view. Okay, you can see?
Yeah.
Okay. Bacterial keratitis is a very common problem in our region, and it is a sight-threatening cause for loss of vision. Most commonly, it is after trauma or the wrong use of contact lens with bad hygiene. In our area, we get bacterial keratitis more common after eyelid problems due to prevalence of trachoma. The treatment should be started as soon as possible with antibiotics after taking the swabs and the smears and culture as talked by Dr. Siddab. Later, after the clinical response, we will see if we can do surgery or after medical failure. The predisposing factors for bacterial keratitis, eyelid lesions like entropion and ectropion, especially after trachoma, tear film instability with depression of the normal ocular flora, or aggressive bacteria that can pass through the intact epithelium like Neisseria gonorrhea or Haemophilus influenza. Trauma like chemical or radiation, contact lens use, iatrogenic causes, contaminated water or solutions, ocular surface diseases like Stevens-Johnson syndrome predisposed for bacterial keratitis, vitamin A deficiency, and immune suppressive diseases. What we see in bacterial keratitis, usually disruption of the corneal epithelium by the bacteria. It will enter the cornea, proliferate, produce proteolytic enzymes that cause collagen fibril destruction. Usually we find it at the edge of the infiltration or in the center of the ulceration. This will induce acute inflammatory response to the bacteria, followed by vascular congestion, edema, limbal vessels, and inflammatory response. Later, it will pass through to the stromal destruction and liquefaction. Clinical presentation, usually with pain, drop of vision, discharge, tearing, photophobia, congestion, swelling. Sometimes they present with hypopyon and corneal perforation. We have to take a good history to know the cause of the problem, symptoms, full slit lamp examination, because the location of the ulcer, the shape, the edge, the corneal clearance will give us hint about the cause of the bacteria, microorganism. Severity should be assessed if there's thinning in the cornea, impending perforation, scleral involvement, or anterior chamber, or even endophthalmitis. It is caused by, we should do gram stains, as said before by Dr. Sindab, blood agar, thioglycolate, chocolate agar. Even we should take, if we suspect contact lens contamination, from the solution, and the case of the contact lens should be also examined. We assess the patient by drawing or photography to see the progression of the bacterial keratitis day by day. We have the bacterial keratitis, as said, gram-positive, Staph aureus, Staph epidermis, strep pneumonia, bacilli, or gram-negative, Pseudomonas aeruginosa, Neisseria gonorrhea, and less common Moraxella, Escherichia coli, Klebsiella, and atypical mycobacteria. They all cause bacterial keratitis. From the shape of the ulcer or the infection will show us something about the microorganism, like in gram-positive, staph ulcers, like here, they are well circumscribed, centrally clean. We have clear cornea with congestion around. Strep is a serpiginous ulcerative with hypopyon, usually they present. Pneumococcal ulcers due to trauma. They extend centrally with severe anterior chamber reaction and going for melting rapidly. Bacilli, they have ring ulcers, and they are usually with the soil contamination. Nocardia keratitis, they waxes and wane and have multiple chalky infiltrate-like microcytic filaments. Gram-negative, Pseudomonas infection, usually due to trauma or contact lens contamination. They have central suppuration with surrounding ground glass appearance, and it may progress to perforation within few days after decimatocyl formation. Neisseria gonorrhea, which is a sexually transmitted disease found in Ophthalmia neonatorum, is a very progressive conjunctivitis with fulminant keratitis that penetrate the normal epithelium. We have also Moraxella infections and anaerobes. It's not moving. Oh. I'm sorry. You can hear me?
Yeah, we can hear you, but the slide is stopped there in the back to the first page. Yeah, that's fine now.
Okay. We should start treatment as soon as the patients come to us, but after taking the smears and the cultures, we should start by
It's not moving, Dr. Razan?
I think she has problem with the net because her picture is freezed.
Ah, the picture is freezed, unfortunately. I didn't. Yeah, now she returned back, I think. Now Razan, Dr. Razan, you are with us.
yes, I hear you, but I
You stop the
Internet.
sharing.
Oh, internet.
Can you share your screen again, Dr.
I will try
Razan,
again.
please?
I will try.
Yes, but you need to open your presentation, Dr. Razan. No, you need to go to your presentation. Yeah. You go to your desktop, yes. No, you can close this. Okay, yes. Okay, now the first screen, the first slide now. You still have 2 minutes, Dr. Razan. If you like to go through the managements, please.
Okay, we start by broad spectrum antibiotics. We have to start aggressively every half an hour of every hour. Then according to the, what happened? Okay. I'm sorry for this. We use broad spectrum antibiotics like cephalosporins, vancomycin, and mycoplasmicides. And lately we are using fluoroquinolones. We use it in the first few days aggressively, then we taper according to the response. We have to use cycloplegic eye drops for pain relief. Sometimes we can use anti-inflammatories. Steroid eye drops are referred and deferred later. After the infection subsides, we can start the steroids to decrease the inflammatory response and decrease the corneal opacity. Systemic antibiotics, according to the case and the cause, if there are systemic signs, we use systemic antibiotics. We have also sometimes to use bandage contact lenses if there is impending perforation, especially after the infection will reside and there's no discharge. Sometimes we can refer to amniotic membrane or conjunctival flap, also if we have corneal perforation. Tectonic grafts sometimes are used as an emergency if there is impending perforation. And now some people are starting to use corneal cross-linking as a direct antimicrobial effect on the bacteria, and it also enhances the corneal resistance to enzyme degradation by the proteolytic enzymes.
Exactly.
Sorry for what happened. Thank you very much.
Thank you, Dr. Razan.
No.
Can you stop sharing your screen, please?
Okay.
Our next speaker will be Dr. Edward Alfonso. Hello, Dr. Edward. He's the director of the ophthalmology at the University of Miami, Bascom Palmer. Thank you for joining us.
How are you? And happy Valentine's Day to all of you. We are celebrating Valentine's Day in the US, so big heart from me to you.
Thank you.
Yeah, my presentation is already videotaped, so that we wouldn't have any problems. So if you could just play it, and I'll hang around for any questions at the end.
Thank you very much. Please start the presentation.
It is an honor for me to give this talk on fungal keratitis update, and in particularly Fusarium fungal keratitis. These are my financial disclosures. The risk factors of Fusarium keratitis are well known. They are primarily related to trauma with contaminated vegetation and soil. This is primarily in suburban areas. In urban areas, the most common risk factor for this is contact lens use. The key to making a diagnosis is to obtain a good specimen, and we like to scrape with a blade and use the edges, the bed, and the deep stroma, as you see in the picture on the left. And in this case, it's a Kimura spatula. On the right, you see different ways of obtaining a specimen, one by passing an Ado silk suture, and the second one by doing a lamellar keratectomy and obtaining the specimen from the stroma, as you will see. A corneal biopsy is easy to do at the slit lamp with topical anesthetics and a speculum. And here you see a dermatologic trephine doing the biopsy, performing the biopsy, holding with 0.12s and a blade and cutting out a piece of the anterior stroma. It is also important to obtain specimens that may be available from the contact lens case, or the other paraphernalia that the patient may be using in their eyes that may harbor the organism. Imaging is important in that we can see the organism on confocal microscopy. Here you see a picture of Fusarium keratitis where the hyphae can be detected by this methodology, which has a 95% confidence level for both sensitivity and specificity. The OCT is also important to consider. In this case, we're using the OCT to be able to detect the depth of the penetration of the ulceration so that we can plan whether a lamellar or a penetrating keratoplasty is the best option on this patient. In this case, we see that the organism has already penetrated with its inflammation through Descemet's membrane, and there is a significant amount of material in the anterior chamber, so we would likely choose a penetrating keratoplasty in this case. The Genome Research Project has helped us tremendously in being able to look at Fusarium as an organism and its encoding genes, primarily in the ITS region of the nuclear ribosomal DNA. And by looking at this, we can tell different characteristics of the organism, and it helps us identify the organism, where the organism came from, the sensitivity profile, as well as the pathogenicity, which includes its mycotoxin production. In terms of treatment, topical antifungals continue to be the mainstay of treatment. The commercially available natamycin, 5%, continues to be the drug of choice, and amphotericin is the second drug most commonly used. And the methyl ester form of it is more water soluble, less toxic, and has a similar MIC, so is the preferred form of the amphotericin B. The MUT study, Mycotic Ulcer Treatment Trial, randomized the use of topical natamycin to voriconazole, and it showed that topical natamycin is superior to voriconazole when we treat filamentous cases, and that natamycin was even better for just the Fusarium cases. There was really no difference between the treatments of using natamycin or voriconazole for non-Fusarium cases. It also showed in another review of the data that oral voriconazole treatment is indicated in Fusarium keratitis. It was additive to the use of topical natamycin in its effectiveness in eradicating the organism. We have used the molecular analysis in our laboratory to derive clinical correlations to the molecular analysis of the organism, and what we found was the classification is important in assisting us in decision making, because natamycin is better against Fusarium solani and Boricol is not as effective. It is important for us to know whether we're treating Fusarium solani or not in making these decisions. We also found out that Fusarium solani is less likely to respond to any medical treatment, including natamycin, and it's more likely to require a keratoplasty, either penetrating or lamellar, when we compare these cases to the Fusarium non-solani cases. When medical treatment is exhaustive and doesn't seem to be helping us anymore, we can try other alternatives, and both cross-linking as well as photodynamic rose-bangle therapy, as advocated by Dr. Guillermo Amezcua and his team at Bascom Palmer. It shows, like for example, in this 56-year-old female, that the use of this treatment took this case from almost getting ready to have to give up to a situation where the organism was eradicated and a corneal scarring was left. I want to finish up by talking about mycotoxins because they're really an integral part of a fungal keratitis, and this is an area where we're learning more, and we'll be able to come up with probably the newest treatments to this disease. The mycotoxins of Fusarium aid the organism in its penetration, necrosis, and can also cause a trabeculitis with hypertension. This was a patient who had a penetrating keratoplasty for Fusarium keratitis, persistence of the organism in the anterior chamber causing a trabeculitis, a pressure of 70, not amenable to any surgical or medical treatment. Also, Fusarium keratitis can progress to endophthalmitis, and in a 15-year study, we saw that about 0.5% of our cases of microbial keratitis can progress to endophthalmitis, but fungal keratitis comprise 78% of these primary keratitis that progress to endophthalmitis. So even though it's a low probability, fungi have much more advantages over bacteria to cause an endophthalmitis. So you have to be very aggressive with the treatment of this disease. We don't like to use corticosteroids in this disease. It's dangerous. It causes diagnostic challenges and may not be efficacious against the inflammation caused by mycotoxins and fungi. If we decide to do surgery, the postoperative management after a penetrating or lamellar keratoplasty is to continue with topical and systemic antifungals, to continue using cyclosporin A or tricolimus as a way to control the immune response, and to avoid the use of topical or systemic steroids in the immediate postoperative period. These should not be used until we know for sure that we have eradicated the organism from the eye, and this may take several weeks to months. So to finalize, our current recommendations are based on accurate diagnosis, and our new molecular diagnostic techniques help in this area. In terms of medical therapy for filamentous keratitis, natamycin is the drug of choice. For non-filamentous yeast, amphotericin and voriconazole can be used. As I said, additive oral and intrastromal voriconazole help. Surgical treatment should be early, especially in cases of Fusarium solani, and continuous debridement, as well as early lamellar or penetrating keratoplasty should be used. Other therapies include the use of cyclosporin and other non-steroidal immunosuppressants for post-keratoplasty cases. We definitely continue to remind you to avoid steroids. Cross-linking and photodynamic therapy may be of help. And further molecular characterization of these organisms, especially to look for the mycotoxins that are likely to be deadly to the human cell, such as the FUM1, that is more associated with the need for a penetrating keratoplasty in these cases. And in the future, we hope that we continue to study mycotoxins, because this may be a way to control the destruction of the tissues in these cases. Thank you very much. And should you have any questions, please do not hesitate to get in touch with me. Here's my information. And thank you very much for listening.
Thank you, Dr. Edward. Thank you very much for this nice presentation. Our next speaker will be Dr. Osama.
Good evening. Thank you for the invitation. So basically, I'm going to talk about microsporidium keratitis. It's microsporidia is emerging ocular pathogen. We don't.
I'm not seeing your presentation, Dr. Osama.
Okay. Is it?
Can you open?
I share it. Is it? Stop share it and open again. See what. Is it coming now?
Yeah,
Yes.
you can just
Now,
continue.
can
We
you
will see it.
Can you see it now?
Yeah, but we are just seeing that your file content, microsporidium talk.
Open it. I know, but it's just I'll open it
Yeah,
again.
just open it again. Yeah, it's opening.
Is it open now?
No, it's not.
Stop sharing again and close it and open
Yeah,
it
okay.
again. Okay.
Mm-hmm.
Not sure why.
My advice is that we need to open the any presentation on the desktop. Keep it open
Yeah, is it
behind
open now?
the
Is it
screen.
open now?
No. Stop sharing, Osama, and open it away from sharing. Keep it behind and then share.
Yeah,
Open
it's
it.
behind.
Yeah, keep it behind. Then now share. See?
Is it open again now?
Yeah, now it's open. See, I'm very helpful for you. See,
Lucky me.
Osama?
Thank you very much. Thank you
Most
very much.
welcome, my dear. Most
But
welcome.
hopefully,
Anytime.
hopefully will come now the screen.
Okay, yeah.
Now is it starting now there?
Yeah,
moving?
yeah, starting very beautifully presented and okay, go on.
Thank
Go
you
ahead.
very much. So the microsporidium is emerging ocular pathogen. It's due to increased awareness and I think improving diagnostic capacity, we see them more than before. The microsporidia basically is a tiny spore-forming obligate intracellular protozoa parasite. It's belonging to phylum Microsporidium. It's recently reclassified it as a fungus. So now it's classified the Microsporidium as a fungus. And at least there's 14 species we know that's affected a human being. Usually it's affecting intestine, sinus, pulmonary, renal, but also ocular infection now become more apparent. It's initially the diagnosis as presupposed infection in patient with AIDS or trauma or contact lens or immune compromise from systemic and topical steroid. But the main reason for it is really exposure to contaminated water, muddy water. And in Asia, they have like a rain season where there's more attacks, and they're reported of outbreak in India and Singapore. And some also reported it even in America with water park, really. People had went to water park and they have some cases reported and medical legal sue for the water park. So the first cases of Microsporidium was diagnosed in 1973. It's considered rare, but I think it's become more of a common. The commonest presentation they call superficial punctate keratoconjunctivitis, but least common is what we call stromal keratitis, but also can cause scleritis and endophthalmitis. The superficial punctate keratoconjunctivitis basically is, you could see like punctate erosion, raised, coarse, large, characteristic like they call stuck appearance. It's like something raised in the epithelium, which is really, once you see it, really you stuck in your brain to see it. It's different than adenovirus flap. So this is a raised one. And later it would cause like luminal keratitis like adenovirus. However, the deeper corneal stromal keratitis is different. This is happening in immune competent patient. It's have a slow chronic progressive infection. It could mimic like a small or multiple. It could have ulcerated, but usually initial diagnosis, most of the reported cases is mimic like herpetic, fungal, or typical mycobacteria. So usually they diagnose it late. could present it with corneal vascularization, but later on, if not treated well, it could perforate it. And usually they have very poor prognosis. Diagnostic method, cornea scrape is the most important way to diagnose corneal conjunctiva, and you send it for special stain. Usually modified trachome stain, that's a very high percentage to be positive. QOIC and cauliflower positive, also 100% you could get the stain. Nelson, 96% in study. Still gram stain and Gims stain, it can give you some 80 to 75% of the staining. The other diagnostic method, PCR, confocal microscopy really is very helpful for these cases. For stromal one, biopsy is very useful. You cannot grow the microsporidium, so you need to grow it only possible in cell culture, so it's not easy available to do it in the normal labs. But you could differentiate the microsporidium species by PCR or immunofluorescence or electron microscope. So they have especially, they have like different characteristic looking under the microscope. The treatment of microsporidial conjunctivitis, they have too many different medication. The good thing is in the keratoconjunctivitis is usually self-limiting disease. So people improve it, whatever medication you use. There's different modality of treatment. The first one is the topical antiparasitic drugs, same like acanthamoeba. So chlorhexidine, BHMB, Brulin, all is very effective. Topical antibiotic also, hemixidine, neosporin. Fluoroconazole is also very effective. All the different clonazole is still also very effective in it. Some people use antifungal, voriconazole, anatomycin. And with if there's involvement in stroma, you may consider systemic therapy, itraconazole, or more people use albendazole, which is for worm in the intestine. So we don't familiar, but this is the other medication people using. Patient with stromal inflammation may require topical steroid, but if it's usually resolved by itself and self-limiting, that's one advance. But however, the microbial microsporidium stromal keratitis is completely different pattern. It's difficult to treat. There's no definite medical treatment. Usually we make using a mixed BHMB, chlorhexidine, Brulin, and fluoroquinolone. But you need to consider all the medication, albendazole or itraconazole or combined. But majority of the patient really, they may need therapeutic cornea graft, and usually you need to consider penetrating keratoblasty because the Miller graft, they have very high risk of recurrent. This is one study looking to microsporidial stromal keratitis outcome of 34 cases. Most common misdiagnosis with this patient, 27 initial diagnosed as herpes simplex keratitis, 18% misdiagnosed as fungal keratitis. It's very common to misdiagnose these cases and delay the diagnosis. Microbiology, cornea scrape, it was positive in 47 cases, but histopathology, because the late diagnosis was more deeper, so it need microbiology, histopathology to diagnose 92% of cases. Surgical management, really it was very high. 74% of the patient need cornea graft, which is very high. This is one patient, basically we saw him in our hospital. Basically his herpes simplex keratitis. He had recurrent 2017, he had attack, and 2019 January he had another attack of herpes simplex keratitis. Treated like any herpes simplex keratitis with topical dexamethasone, Valtrax. Patient improved. He had another attack in March last year, so we also the same increased the steroid, the cyclovir, and after 2 weeks the infiltrate of the stroma improved. But after 3 weeks, he just have punctate staining in the cornea, and just it looked like herpetic acid because the patient is recurrent herpetic. So we always think about herpetic. So we give him Vergan, but that time just we give Vigamox to just do secondary infection, and you could see the epithelium dots in the cornea. And then after 2 weeks, everything is settled down. So that epithelium lesion is improved, and the patient still have some stromal keratitis from herpetic. But surprisingly, after 2 months, he had another recurrent of multiple punctate stain. This time, the punctate stain looked really it's different than the herpetic and really looked like raised punctate stain. So we suspected microsporidium. We taken cornea scrape, stain, culture, PCR. We increased the cyclovir because we know that he's herpetic. But we started Vigamox, albendazole. We sent the gram culture. This told us a gram positive foci. I think that's misdiagnosed as microsporidia, could be diagnosed as the misdiagnosis as gram-positive cocci. So 2 weeks, that the surface epithelium has improved, which everything settled down. Later on, that started to develop stroma, more infiltrating the stroma. Patient is he lived between here and London, so he went to London. So we did the confocal microscopy there in London. It's negative, so they did biopsy, and the biopsy detected microsporidium. So we treat him with BHMB, chlorhexidine, Vigamox, and we kept it with albendazole. We stopped the steroid, and the patient slowly, it's the stromal lesion is improved. But as you know, he had corneal scar because of this long-standing mixed between herpetic keratitis. On top of that, he had microsporidium. There's another case which is I just saw it really 3 months ago. Basically, he just came with red eye for about 4 days, and he had also same characteristic, this benched raised epithelium lesion. So my diagnosis, it looked like microsporidium, and bring him next day. I did corneal scrape. It was negative, but it's just with I give him albendazole and Vigamox, and the patient came after he missed the first appointment, but came after 10 days with the medication, the Vigamox really, and that's everything clear up. It's really, as I mentioned, the microsporidium keratotic conjunctivitis usually can self-limiting, but Vigamox seems to be also do the trick for this patient and the previous one. So conclusion, microsporidium keratitis can occur in otherwise healthy individual. Has an index of suspicion is help diagnose of this uncommon keratitis. Really very important with any corneal ulcer. You need to do corneal scrape, and you may need to do corneal biopsy to establish the diagnosis. Keratotic conjunctivitis has characteristic raised coarse epithelium lesion associated with conjunctivitis. Really, once you see it, and you can see it with the picture, really it's very different from all other epithelium keratitis. It's different from adenovirus. It's much raised. It's an unusual characteristic, but really, once you see it, I think it will stick to your brain and you may not miss it. Stromal keratitis, the initial picture could mimic herpes simplex keratitis or fungal. So always remember that if the patient not responding well, you may consider microsporidium in the differential diagnosis. The problem is very slow prognosis. It takes a long time, and usually they may need the cornea graft. And thank you very much.
Great, thanks, Dr. Osama. It was a very comprehensive on microsporidia. I think that Dr. Khalid with us to introduce me, and I will start because we've been late for 3 minutes. Dr. Osama usually punish me with this.
No, it's 18, by the way, it's exact time.
Okay. Anyway.
Our next speaker will be Dr. Safwan Al-Bayati. He will be talking about Acanthamoeba keratitis.
You had 12 minutes, Safwan.
Great, thanks for you, Dr. Khalid.
At the end.
I just thank you for having me here with Dr. Osama and Dr. Mohammed Al-Amri, and I will start my presentation. I think that we've mentioned a lot, and Sandeep always, he's helpful for me here. He talked a lot about how we are seeing Acanthamoeba, that resistant organism. So I will start with microbiology, free living organism commonly found in water and soil, prey on the other microbes existing in two form, trophozoite and cyst. But what cyst? Is a double-walled cyst that's extremely resistant to extreme of temperature and desiccation and irradiation and antimicrobial agent and other changes in environment. Acanthamoeba keratitis first described in 1975 by Johns, generally rare infection characterized by periodic outbreaks, incidence of 1.49 to 2.1 cases per million contact lens wearer per year. Approximately 90% of cases occurring in contact lens wearer. As a risk factor is a contact lens wearer, more than 90. Trauma is carrying another risk factor, but mainly is a contact lens in a swimming pool. So that's why this percentage, I think that it's a little bit now more with the use of, or fantasy of use of contact lens while they are swimming. Now, one of the important presentation is early disease before 1 month is the epitheliopathy and punctate keratopathy, and epithelial or subepithelial infiltration, pseudodendrites, and radial keratoneuritis. The important issues that we are facing is that a masking between herpetic keratitis and the acanthamoeba. Unfortunately, they are presenting in two different ways. Clinically means that the symptoms different, but the signs dendritic. So I will show you one of the cases that has a disaster end, but it started with a simple end, or the simple start with the epitheliopathy, and that was in the dendritic form. The pain is crucial to differentiate between them. And usually history of contact lens with the dendritic, it's very rare to be herpetic. And the sensation of the cornea in any herpetic is crucial also to differentiate the acanthamoeba from dendritic. But both, if we are looking to the cornea without any history, without any test, we can mask or we can miss the case and treat the case as a herpetic, and that's what's happened with this lady. Sorry here. Yes. Now the epitheliopathy, as it's shown on the left up, it sometimes mimic the dendritic, but other times it can have some filamentary form or a defect in the center. Subepithelial infiltration, that's right, on up, it shows, and just like annular keratitis, while pseudodendritic, it sometimes and it mimic the herpetic dendritis in a dramatic way. Epithelial ridges, it's difficult to have it, and I didn't see it personally. Now, pre-neural infiltration and a radial distribution, yes, I saw it in one of my patients, and it's clearly resulted from the clustering of acanthamoeba trophozoite around corneal stromal nerves, resulting in a swelling of these nerves. So that's why they start to be visible. The trophozoite kill nerve cells by direct cytolysis and apoptosis, explaining the nerve's pain, the severe pain experienced in acanthamoeba keratitis. And as what I said, that sometimes it's present in a classical ring infiltration, whether it is a central or the large one in advanced form, a frank ulceration, secondary sterile anterior uveitis, sometimes with the hypopion, and that's what's happened with both my patients that present now, or you will see it later. Corneal melt, I didn't see a corneal melt because I'm using the cross-linking. A corneal perforation, that also I didn't see it, also because I'm using cross-linking in our treatment. Now, that's the sterile hypopion, and in the lower right is the corneal melt, and the lower left the classical ring ulcer of or abscess of acanthamoeba. Now, the early diagnosis and prompt delivery of appropriate medical therapy is the essential cure and a good prognosis. If effective therapy is delayed for 3 weeks or more, the prognosis is deteriorate. And unfortunately, we have all the element to delay because of the diagnosis. And second things is that the lack of the treatment. We don't have a ready a trademark or trade drops for the anti-acanthamoeba, so we need to prepare it. And in the beginning, chlorhexidine was not an available issue to prepare it, and it's difficult to prepare. Acanthamoeba keratitis should be considered in any case of corneal trauma, complicated exposure to soil, as I said, and contaminated water. Diagnosis is made by, as Sandeep said, scraping and staining with Gemsa stain and other stain, but it's very difficult till now to isolate this organism. Culture yield is laboratory dependent, with a large studies report on 35% only up to 50 positive. So we might have 50% or 85 or 75% negative. significant number of cases are treated based on clinical presentation, and this is most of the doctors, they agree that the clinical presentation of acanthamoeba, it's more than enough to go through biopsy, and definitely if we have a confocal, that will be great, but most of our hospitals, they don't have, or our centers, they don't have a confocal microscope. Lamellar corneal biopsy may be required to establish the diagnosis in some cases, but I'm sure that the clinical presentation is more reliable now on that, and unless there is a resistance to a classical treatment. Contact lens and related parapharyngeal can be examined, but significant contamination without disease has been demonstrated, and that's what we demonstrate in all our cases that we treat. We didn't demonstrate the trophozoite or the double cyst. Now, this is the confocal microscope. Sorry, this is the lab study for a corneal biopsy, shows the double cyst with some of the trophozoite, acanthamoeba species, stained with the optical whitening agent, calcofluor, white, and examined using ultraviolet epifluorescent. Corneal biopsy showing acanthamoeba cyst with acid shift. And this is the confocal microscope to show the double cyst. Maybe Sandeep, he show a better picture with the confocal showing clearly the double cyst, double-walled cyst within the stroma. Now, that's the scale for the treatment that we have, and mainly the chlorhexidine that can treat the trophozoite, and proline, polyhexamethylene, so that can treat, the propamidine estenoid, which is the proline, that can treat and interfere with the double-walled cyst. And the main use is the chlorhexidine, which we are preparing it from every 3 days to 5 days maximally, from the chlorhexidine content of detergent or mouthwash. And proline is available as a drops. Usually, I'm using 0.04 in the severe cases and 0.02 as Osama mentioned in his cases that we are using also in mild cases. Here we need to talk about the combined treatment adjunct of a cross-linking and anti-acanthamoeba is the advised treatment. In my opinion, it gives the better prognosis and shortening the treatment period in the treatment of the active acanthamoeba. And now this is the first case. If we will see that it's essential for a 56 years lady, presented female with the contact lens users. She swam day before. This is 2 days, mainly 2 days before coming to us. She swam with the contact lens, and she slept with the contact lens. Morning, she felt a discomfort, red eye, and foreign body sensation, and she started to have a blurring vision. That's why she searched for a nearest doctor, and she came to me. And the immediate things that I did it, because I didn't have any treatment for her. The proline, she has the issues with the contact lens. So we start scraping. We made a slide for her for a direct staining and for culturing. And after that, I didn't have any treatment. I didn't have a proline. Proline wasn't available in most of the hospitals that I know, and I called them directly. And chlorhexidine preparation at that time, it wasn't available. We didn't know that there is a lot of mouthwash with the chlorhexidine concentration. So we used a therapeutic cross-linking 30 minutes for 30 milliwatts, for 30 minutes. This is the second day after this is the third day after the cross-linking. she started to have sterile hypopyon. And this is the 4th day. The 5th day, that you can see that the ulcers start to be more quiet, and the corneal edema around it start to be better, and the sterile hypopyon less. And this is the 8th day, and that's the 2nd week where I start to, this is without any Proline and any chlorhexidine. And we were searching for the medication while she was taking only antibiotic for secondary bacterial infection. And you can see that the fluorescein staining start to be much less. We have Proline. Osama help us. Always Osama help us with the medication. So we have 1 bottle in Morphew Eye Hospital. So we took it and we start aggressively every hours, 0.1% of propamidine, and that's her condition 24 hours after. But I decide to repeat the cross-linking. And that's the 1st day post 2nd cross-linking. Usually we have the epithelial defect is more. This is the 1 week, the epithelial defects start to be less, and then less, and sorry. Then we start the chlorhexidine. We found it as a powder, and we dissolved it at this stage to 0.02. And we start, and there was a dramatic changes in the treatment. 2 weeks later, the epithelial defect, you can see that it's sealed. And this is 1 month later, fully sealing. And now the patient, she's one of the area manager for the Emirate airline in Senegal. So she traveled and she sent me all the reports that she has. Her vision is improved and her condition is stable. The second case, unfortunately, that she present to one center with a dendritic ulcer, and she's been treated as a herpetic keratitis. And that's what she present to me. She's a 40 years female, presented with the reduction of vision, with a history of contact lens used for only 1 day in her life, and that was the bad day in her life, with foreign body sensation and pain, and severe pain from the first.
2 minutes. 2 minutes.
Yeah, I'm almost finished. I have four photos, and that will be finished. And we can see that the presentation with a ring ulcer that presented to me, and hypopyon. And this is the fluorescein. And she present with the first time, that's the first presentation that she got the picture of it. And this is the second, or few days or in another center with a geographical ulcer. And they thought that it's dendritic, and they treat her with the antiviral, and then they start, because they're resistant of ulcer, they start the steroid, and we end with this. And now, after the treatment, she had a 2-time cross-linking, and with aggressive treatment with chlorhexidine. I think that Osama know the patient, and Dr. Sandeep also know the patient, with aggressive use of chlorhexidine hourly from the beginning, and a Proline hourly, and then we tapered to the end. Now she's using it twice a day with a topical steroid. And when we start using the steroid, the epithelial regeneration started, and now we are ending with this condition with a central corneal opacity, more quiet eye, and now we are preparing her for PKP. And I think, in my conclusion, that the early detection of this kind of keratitis is crucial. And in spite of that, the corneal infection, we need to think about it after contact lens. It's carry 3 main important issues that we need to think about: the acanthamoeba and Pseudomonas and fungal. And pain is the landmark for acanthamoeba. So in dendritic corneal ulcer, with a wearer with the history of contact lens wearer, mostly it's an acanthamoeba. It's not a dendritic or hepatic keratitis. Early detection and treatment is crucial, saving cornea and saving the eye. cross-linking as an adjunctive to the anti-acanthamoeba is one of the modality that shorten the time of treatment and save the cornea. Thank you very much.
Thank you, Dr. Safwan. Very interesting. Thank you for presenting these cases. The first case, it was documented to be acanthamoeba.
Well, see, we didn't isolate any microbial. We sent the scrap twice. Sorry?
On the clinical picture, it was diagnosed.
Yes, clinically, both of them clinically, actually. Okay. Both of them, they did well with the anti-acanthamoeba treatment and the cross-linking. And I saw the first case was at least 2 weeks or more, I think that 3 weeks without any treatment, without any anti-acanthamoeba treatment, only on cross-linking until we reach to get the acanthamoeba treatment. And she's doing very well without any need for any further. Even I thought that she will be in need for a topical laser or trans-PRK or PTK just to enhance or remove this superficial opacity, but she didn't. Her vision returned back to her accepting, at least she was seeing success. Now she's seeing at least 20/30 or 20/40, and she's happy.
Thank you very much. I have a question to Dr. Alfonso about the fungal keratitis. Also, we have problems with the antifungal, especially the natamycin eye drops. We are not available. What about the role of the fluconazole on these patients, and the role of, is there any role for doxycycline capsules, oral treatment in the fungal keratitis?
So first on the other antifungals, so the azoles all are fairly similar in their sensitivity profiles. So what we know from the data is that the azoles, especially the triazoles, like fluconazole, don't do as well in fusarium keratitis, and that has been borne out now by the data of the MUT study as well as retrospective case series, and as well as our molecular studies that we have done in our laboratory. So what I can tell you is that I would probably stay away from the use of the azoles in fusarium keratitis, especially fusarium solani. So as the first line drug of choice, natamycin is okay. The triazoles are okay if you don't have natamycin to start with, but I would certainly try to obtain some natamycin to treat if it's a fusarium. For the other filamentous and non-filamentous fungi, the azoles are probably as good as natamycin, and certainly we have a good experience with amphotericin also, and I, as I said in my talk, the use of amphotericin should also be considered, especially for the non-filamentous or yeast fungi. The second question, in terms of the doxycycline, there is evidence that doxycycline stabilizes some of the enzymes that cause destruction of the collagen in the cornea. So that is something that can be considered as an adjunctive use, but not as treatment. And there's nothing wrong with placing the patient on oral doxycycline. The problem is that if we do, as I said in the talk, both topical natamycin as well as oral voriconazole, patients tend not to do well with so many systemic therapies. But certainly the breakdown of the collagen has been shown to be modulated with the use of the doxycycline or tetracyclines.
Thank you very much. Any questions from the speakers? Dr. Safwan.
About microsporidium, how is the other experience? Just last 2 years, I see like 4 cases. I haven't seen them before. I'm not sure what other people experience. Does they see them now more, microsporidium?
The problem of microsporidia, it need a biopsy. So I don't think so that we can isolate. So that's the big problem that we have it in most of these resistant microorganisms. So in your case, if they didn't do a biopsy, they could continue treating this case with the antiviral. This is the issue. So biopsy clue that this is a microsporidia. I don't think so that we can do it. So that's why maybe 20 or 30% of our cases that we are treating them with the antiviral, they are a microsporidia. That's the issue. But the important points that I need to highlight it here, there was a case between me and Osama. She present with early dendritic, and she had acanthamoeba. So the early issues that we did is that the debridement of the epithelium. And this is the early treatment for both, for dendritic and for acanthamoeba. So if we are doing it, we will eliminate more than 80% of the trophozoite. And here, the neuropathy that this patient, it's been stopped directly when I start that, because he sent it for the preparation of medication. And when we start promptly, she returned back to him as if nothing happened. So it didn't even leave any trace on the cornea. So anyway, I think that before starting the antiviral, we need to reassess and consider the history, because I'm sure that the doctor that he started with the last case, he didn't ask the patient whether she was using contact lens or not. And the pain, maybe it was moderate. That's why she didn't explain to him that's pain. So the doctor start antiviral directly, and she end up with the steroid topically, and then flare up with this ring corneal ulcer or abscess.
One comment, by the way, about one thing is interesting, really, I noticed. It's itraconazole now available as ointment from India, and really is useful, okay? And it's very cheap to have it back up for, it's almost like 20 dirham, itraconazole ointment.
Yes, interesting.
Dr. Khalid, I think that we need to leave because we have another session.
Okay. Thank you very much. Thank you all for this nice presentations. I hope to see you in physical soon, inshallah. Thank you. Take care.
Thank you very much, everyone. Thank you.
Be safe.